Welcome to episode 17 of the Pro PA podcast. I'm your host, Prof. G, and today we're tackling the final topic in our pulmonary infection series on pulmonary tuberculosis, or TB. In this episode, we'll cover the kinder patho for TB, who's at risk for developing pulmonary TB, how to diagnose and manage TB, including latent and active disease, and of course, we'll end with vignette-style questions to test your knowledge. Now let's get started. First, let's look at the kinder patho. What is tuberculosis? Tuberculosis, or TB, is a chronic infectious disease caused by the bacterium Mycobacterium tuberculosis. TB primarily affects the lungs, but it can disseminate to virtually any organ, like the lymph nodes, bones, meninges, and this infection spreads via airborne droplets, making it highly contagious in close contact settings. The pathophysiology in a nutshell is that after inhalation, M. tuberculosis is engulfed by alveolar macrophages, but it survives and multiplies inside of them. And the immune system forms granulomas, so this is collections of macrophages, T cells, and fibrous tissue, and this tries to wall off the infection. However, TB can remain latent for years or progress to active disease, particularly if the immune system weakens. So, who is at risk for TB? There are certain populations that are higher risk for both latent TB infection, or LTBI, and progression to active disease. These are close contacts, so family members or roommates of active TB patients. We also see it in immunocompromised patients like HIV/AIDS patients, patients on chemotherapy, or long-term corticosteroid use. We also see TB in higher risk populations like healthcare workers. So, occupational exposure to undiagnosed TB cases can put healthcare workers at higher risk for developing TB. We also see it in foreign born populations, so high prevalence in countries like India, China, and sub Saharan Africa. So, make sure to look for that in a vignette that they recently immigrated from those type of countries. Another thing that we see are social risk factors like homelessness, incarceration, or substance use disorder. So, how do these TB patients typically present clinically? First of all, we have to break it down by the different types of TB infection. So, for primary tuberculosis, the initial infection, you're often asymptomatic. They usually present with maybe a mild flu like illness, but this is seen more commonly in children and adolescents. Now, latent TB or LTBI, they will have no symptoms, but they will have a positive TB test, either a PPD or an IGRA. And this is where they are not contagious until reactivation occurs. Now, active tuberculosis is symptoms that typically develop over weeks to months and include fever, night sweats, weight loss, which are the classic constitutional symptoms. And they also tend to have this persistent cough, which can be productive or dry. Also, patients with TB can have hemoptysis, or blood in the sputum, and this can be usually found in more advanced disease. Physical exam findings may reveal crackles or rhonchi, but they're often very nonspecific. So, how do we work up tuberculosis? Well, we can do screening tests. PPD, or tuberculin skin test, is positive if induration meets a certain size criteria, and this really varies by risk group, and this is a must-know topic. I have seen many questions on this, so you need to know not only the measurements, but the different risk categories and those who are in each risk category. So for those that have no known risk factors, just the general population, a positive PPD test will be a greater than or equal to 15 millimeters. And this is the induration, not the redness of the test. Then we also have the greater than 10 millimeter. This is when we have recent immigrants, healthcare workers, or homeless populations. So they're going to have a smaller area of induration to become positive. That's 10. Okay. Then we have the most high risk group, which will be our HIV patients, recent close contacts, and the immunosuppressed patients. And these will have a positive PPD if their test is indurated greater than or equal to 5 millimeters. Okay. This is super important. Now, it's important to note that in other countries, they give a TB vaccine. Okay, so if the patient has received a TB vaccine in the past in other countries, we don't do it here in the United States, but if they have received it in other countries, they will have a positive PPD test. So in this population, the screening test that we would use is the IGRA, or the interferon-gamma release assay. And this is the preferred test in patients with the BCG vaccination history or with poor compliance for follow-up. Remember, when we administer a PPD test, we have to have the patient return within 48, 72 hours to have that test read. Some other diagnostic testing for active TB are going to be our chest x ray. So, a reactivation TB is usually going to show cavitary lesions, and these are usually found in the upper lobes. The primary TB, hilar adenopathy, lower to middle lobe consolidation, and in miliary TB, we'll see this diffuse small nodular opacities like millet seed appearance within the chest x ray. Another thing we can look at is the sputum analysis. So we are going to look for an acid fast bacilli stain, which is rapid, but it's a little bit less sensitive. We can also look for a NAAT test, or nucleic acid amplification test, and this is also highly specific for TB. We can also use sputum cultures, which are the gold standard, but they do take several weeks to grow. So, how do we manage tuberculosis? Well, latent TB infection, or LTBI, the preferred regimen is going to be some medications that you're going to need to be very familiar with. These are your ripe medications. The ripe medications include rifampin, isoniazid, pyrazinamide, and ethambutol. So for the LTBI infection, we're going to see that the preferred regimen is going to be isoniazid plus rifampin for weekly for 3 months. An alternative would be INH daily for 9 months, or rifampin daily for 4 months. For active TB, whether it is pulmonary or extrapulmonary, the initial phase we're going to use ripe therapy. So that's the rifampin, isoniazid, pyrazinamide, and ethambutol. We're going to use these medications for 2 months for the initial phase. And then in the continuation phase, we're going to see the rifampin plus isoniazid for 4 months. And the total duration is going to be for about 6 months in most cases, during which we need to monitor for side effects. So I see this tested all the time. Be sure that you know the side effects for ripe therapy. So rifampin. Rifampin is going to cause orange secretion. So patients urinate and their urine is orange colored. Their tears can be orange colored. It can also cause some hepatotoxicity. Isoniazid is going to cause some peripheral neuropathy. You're going to want to give paroxetine along with it, and it can also cause some hepatotoxicity. Pyrazinamide can cause some hyperuricemia and also some hepatotoxicity. And ethambutol starts with an E, which is similar to eye, yeah, your eyeballs. So ethambutol can cause optic neuritis. So you want to definitely check visual acuity and have the patient keep an eye on that. So, as far as infection control, active TB patients require airborne isolation until they're no longer infectious. So, they're going to need to be admitted to the hospital in a reverse isolation room. And they're usually going to be kept in the hospital for about 2 weeks after treatment is initiated before they're let go. Also, patients that are taking these medications are often going to be monitored while they are on the medications to make sure that they are actually taking them. So they might have to go to a community health center to take them. For book med versus street med, so the book med is going to say ripe therapy, strict isolation for active TB. Street med, in the real world, we want to consider compliance, close follow up, especially in patients with social barriers. So remember, the higher risk populations are going to be those homeless, incarcerated, substance use. So we want to make sure that we are using the directly observed therapy, or DOT. This is going to be critical in the high risk populations. And that's what I was mentioning earlier, where we will actually have them come in and take the medication while we are observing them, taking them to make sure that they can eradicate that infection and that they're not out there spreading it to other folks. So let's talk about some quick clinical pearls. Always ask about travel history or high risk exposures, especially like recent incarceration, homeless shelters, when you're considering TB, also immigration status. And as far as the cavitary lesions. The cavitary lesions are usually found in the upper lobes, and this is hallmark for reactivation TB. Another clinical pearl would be that HIV patients with a CD4 count less than 50 are at increased risk for disseminated TB. It's where it travels not just in the lungs, but in other places of the body. All right, now that we've covered that quick rapid fire through TB, let's do a few quick clinical questions to see if we have learned anything. So, first off, we have a 43-year-old man with no significant past medical history who presents with a persistent cough, weight loss, night sweats, and hemoptysis. He recently immigrated from India. Chest x ray shows cavitary lesion in the right upper lobe. What is the most likely diagnosis? Is it A, community acquired pneumonia, B, lung cancer, C, pulmonary tuberculosis, or D, sarcoidosis? Let me know what you think. Well, I don't think this one was too difficult because this is what we're covering today, but the answer was C, pulmonary tuberculosis. In this vignette, you were looking at the combination of weight loss, night sweats, hemoptysis, and a cavitary lesion. And this is a patient from an endemic area, classic for this reactivation TB. All right, question 2. We have a 25-year-old healthcare worker who tests positive on a PPD with 12 millimeters of induration. She denies symptoms of cough, fever, or weight loss, and a chest x-ray is normal. What is the next best step? Is it A, begin RIPE therapy immediately? Is it B, start latent TB treatment with INH and rifampin? Is it B, perform sputum culture for acid-fast bacilli? Or is it D, repeat the PPD in 6 weeks? I'll give you a few seconds to think about it. If you said B, start latent TB treatment with INH and rifampin, you are correct, okay? This patient has a positive PPD and she is completely asymptomatic and has no x-ray findings, which indicates that she has latent TB. This latent TB should be treated to prevent reactivation, and the treatment of choice is going to be that INH plus rifampin. All right. Well, we want to thank you for joining us today in this clinical medicine brief on pulmonary tuberculosis. We have covered everything from the pathophys to clinical presentation to diagnosis and even touched on management. And this episode concludes our pulmonary infection series, but stay tuned for more high-yield topics to help you ace your PANCE and sharpen your clinical skills. As always, if you found this episode helpful, don't forget to follow and turn on notifications so you never miss an episode. And as always, this is the Pro PA podcast, where future pros in medicine are made. I'll catch you in the next episode.